Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be here with Dr. Craig Joseph. Dr. Joseph is the Chief Medical Officer over at Nordic and has done a ton of really exciting things in the past. A lot of interesting stops on his journey, Seattle Children's Hospital, and a whole bunch of other experiences. So, Dr. Joseph, thank you so much for joining us today.
Thank you for having me. I'm excited to be here.
So let's take a little trip down memory lane. Where did you grow up and why healthcare?
Oh, awesome. So grew up both in Detroit. I was born in Detroit and lived in the suburbs of Detroit till I was 10 and moved to Florida, to Miami. And then I went to junior high school, went to college in Miami, then back to Detroit for medical school and residency and got married and started a family and practiced primary care pediatrics and all that stuff.
In Detroit.
Why Detroit? Back in the Detroit area. Yep. All
How
around.
Was that?
It was great. And totally, I enjoyed it. I got to work in a bunch of different practices, two doctor practice with just one other pediatrician, and then other larger ones with 6 or 7 doctors. So it's a different vibe. But I managed to avoid the huge group. So I never worked with, like in a Kaiser Permanente or something else that's with thousands of physicians. So yeah, it was fun. Why healthcare? It just seemed like a fun thing to do. It seemed challenging. I like a challenge. And so, in high school, I said I was going to be pre-med, and then in college, I was pre-med, and then you got to apply and get in, and it's difficult. The training is difficult, but I enjoy a challenge and was able to get through. I got through, so I was excited.
So no, my father was a doctor, my grandfather was a doctor, none of that.
None of that. Nope.
So
I started the trend, but I feel like I'm ending it because my children don't seem to be wanting to follow in my footsteps. And who am I to tell them to?
Exciting, it turns out.
Yeah, well, I'm not your typical physician nowadays. I don't practice now. Right. I maintain my board certifications, maintain my license. Could go back to practice, but don't expect to at this point. I've been kind of jumping into the IT and clinical operations worlds for a long time now. Yeah.
So, I mean, at the end, especially if you don't have family history of doctors, I find it kind of uncommon or somewhat uncommon that people really interact with the healthcare system enough to even want to do that. What was the inspiration, or was there any specific interaction that you had with the system that you were like, this is something I want to do, or something that's broken with the system at such a young age?
I would say it was more kind of a tech. In the early 80s, I was into computers, which was not something a lot of people were doing back then, especially kids. And I had this amazing opportunity in high school in Miami to work at a lab at the University of Miami's medical school. And there was a trauma surgeon for some reason, who had started a computer lab and was doing research in the surgical ICU there. And so I was in high school programming computers that were being used in the surgical ICU of a major academic medical center, and
Really?
just kind of stumbled into that. Yeah. So that kind of got me interested in the combination of tech and healthcare. I thought it was just a side interest of mine. Actually, I had no intention when I went to medical school of combining IT or technology in general with healthcare. I just wanted to be a physician, and it was pretty straightforward. And then after I did it for about 9 years, then I was starting to think, I've learned a lot, and I'd love to be able to kind of help many more patients than I could possibly see, and maybe even help some physicians by making the technology better, which continues to be a lot of what I do.
Yeah. And so making the technology better, so let's dig into the tech a little bit. What did technology look like when you started out?
Well, when I started out practicing, we It was all on paper. So everything was on paper. Our scheduling, if you wanted an appointment, you called and we had a scheduling book. And so there was one person who had that book and couldn't make more than one appointment at a time. All of our records were on paper. If I wanted lab results for something, I would have to get that faxed over to me. I certainly couldn't get that on the computer. We had a computer.
I mean, I know that wasn't even too long ago, but like if you're a doctor trying to see a patient, like, and the patient's 60 years old, how do you go through their chart? How do you do that?
Well, on paper, you just try to deal with the top one or two or three issues. And you're constantly kind of going back and trying to remember, like, hey, why you had a heart attack when? How long ago was that? And who's the cardiologist and when? And this is something that you repeat every single time. And so the patient as historian, the patient as the person who knows the story was essential, because without that person or someone that accompanied that person, you were pretty much out of luck, except for what you knew that happened in your clinic. So you could certainly see your notes and you can flip through those pretty quickly. And if you had an established patient, it was pretty straightforward. Again, as a pediatrician, I generally didn't have those kinds of problems. Most of the patients I saw, I took care of from birth or for a long time at least. And so I got to know them. And once they're in your chart, in your charting system, you have a pretty good way of figuring out what's going on. It's when you go to a specialist, if you're just walking into a cardiologist with this long history of heart problems and operations, that it takes a long time for that first visit. That first visit is a long one, and you're just trying to
basically
grapple.
a book club.
Well, yeah, and and the patient says, "Well, I had a heart surgery," and right. You're like, "Well, I'm going to need more than that." Well, that might be all you get, actually. Right. And so it's really no different than emergency medicine doctors dealing with patients who come in without ID, or today that still happens. But nowadays we have a lot of technology that lets us get a lot of information. Sometimes actually too much information. Mm-hmm. So too little information is bad. Too much information almost is bad, actually, because you're looking usually for a pin in a haystack, and if you don't know exactly how to find it, then you're in trouble.
So let's double click on that for a second. So as we moved over to EHRs and getting everything in an electronic digital form, how has that problem kind of been exacerbated with moving from hard and not very easy access to the data to maybe too much data, and how in your view has that impacted doctors?
Well, it's not as bad as not having any information, but it's close. Yeah. And the reason is that now you're kind of on the hook for it, right? Like, well, doctor, did you have access to the NYU chart? Well, I did, but it spans 10 years, and I had 15 minutes with the patient, and I didn't see that one test result that I probably would have been very helpful to me. And so that's the bad news. And it's been that way for a decade or so, I think. The good news is we've got this thing called AI. Have you heard about that? I came up with that term.
Is it? Oh, yeah. I think
that's my term. Yeah, I made that up.
What does it stand for again? I think I've heard of it.
I don't even know anymore, no. Something about artificial intelligence. I certainly did not make it up. That might have been a lie a minute ago. But I think AI is going to be actually very helpful. It's really, really good at taking lots of information and then summarizing it. Yeah. And so I think that's going to be a big help, because now I can sometimes I'm going to want to summarize, like, hey, look at this literally 10 years of patient care at one big academic medical center, and summarize the cardiac history for me. And that will be helpful. Also, if I know that a test was done, or I know something happened, like, hey, what were all the beta blockers this patient was on? Give me that list of when they started, when they stopped, and any side effects that were noted about them. And I think AIs are pretty good at doing that today. Just the generic GPT, chat GPT that we have today can do a pretty good job. And so I'm very excited about what could happen in the next years or two when we actually focus those GPTs on or generative AI in general on very specific use cases. So for healthcare, we want you to hallucinate a lot less, because we can't really tolerate you making stuff up. but so give us what you can. And if you take 10 years of data and put it down to 2 pages because you can't summarize it anymore, that's an amazing help. So
Yep.
I'm pretty excited about the too much information becoming much less significant.
Yeah, I think you're absolutely spot on. We're entering into that era where the pain of the last 10 years is about to become the gold, because all that unstructured data and all that randomized data is about to become extraordinarily important. And to your point, we're going to very shortly come to the point where if I'm seeing the patient, it's not just going to be a summary, it's going to be an intelligent summary. So if I'm here to see the patient for a specific thing, it'll give me the highlights of everything pertaining to this specific issue, in that patient's entire history. It's not just going to be one summary, right? So that's we're definitely moving into an exciting time. So let's talk about Nordic. What is Nordic, and how is CMOing over there?
How is CMOing? That's awesome. So that's my title, Chief Medical Officer. Nordic's a healthcare management consulting company. We started off really focusing on electronic health records, one big vendor, and that's located near Madison, Wisconsin, where we were founded. And so now we do a lot of exciting things. We still help with technology. So we help large healthcare systems and large hospitals around the world with their technology. But we also help with other things, all aspects of running a hospital. So it's not just the technology that doctors and nurses and patients see, but also the bookkeeping technology and the HR tech and all of that other stuff, as well as just operations. Sometimes people come to us and say, "Hey, we have this problem with the electronic health record. It's not letting us do X, Y, or Z." And sometimes they're right. It is the EHR, and we need to help them kind of configure that. Other times, though, it's, "Hey, you've got an operations problem. You don't have enough nurses on this floor, or your medical assistants are floating through this clinic so quickly that they don't really get to learn how to deal with the doctors at that one clinic, or, Dr. Smith really likes patients to be presented this way, and Dr. Jones wants it the other way." And if you can't get that kind of that vibe going, it makes for a lot of stress. And so sometimes we blame the technology when in fact there are other reasons. And so we try to help our customers and clients solve those issues.
That's awesome. And so it feels like this is maybe a really great balance between your talents on the clinical side and understanding the end user, and also having that keen appreciation and really understanding on the tech side, because that's it's very, I shouldn't say very rare, but it's quite rare. Most doctors are either completely clinical and they, you have to show them 16 times how to send an email, or
now, no doctor shaming here.
The only people worse than doctors at technology is billers, which is wild. But and then you have doctors that are, super, then you have people that are super techie, but they don't understand, the
clinical space.
And
yeah,
that's a much bigger problem, because so many health tech companies are just tech companies. And they're trying to do healthcare. And so, how has kind of your mix of talents, how's that playing out in this role?
Yeah, well, I think it used to be a lot less common than it is now. So when I went, my undergraduate degree was computer science, and then I applied to medical school. And I promise you that pretty much everyone that I was applying to was like, "Wait a second, you're a computer science major. How could you possibly want to come to medical school?" There was nothing illegal about what I was doing. You didn't have to be a biology or a chemistry major, although most people were. You had to take 4 or 5 classes and sit for the MCAT. And if you did that, then you could apply to med school. Now there's a whole specialty called clinical informatics that just didn't exist. I didn't even know what this was maybe 15 years ago. And so now actually there are physicians who have formal training. So first you go to medical school, you do a residency, and then you can do a fellowship in clinical informatics, where you spend 2 years actually learning about technology, about how humans interact with technology, about how to make changes and how to convince people to do the things that you think that they need to do, even when sometimes they don't want to do them. And so that was all of us kind of who started in this field before it even had a name. We're figuring this stuff out as we were going along, literally building that plane. But it's now become, I wouldn't say it's a science, it's become more science-y. We now know about certain areas where we have to focus. And to your point, physicians, I would push back a little and say I think physicians are very tech focused. They like technology. They like technology when it works for them and their patients.
Yes.
Right.
100%.
And that's the pushback that we see. And a lot of it, not all of it, much of it is appropriate, right? Like, hey, this was super easy for me to do on paper. And now it's difficult for me to do. So yeah, you're right. I don't like your technology.
And that has to be the second problem with the fact that most health tech companies are tech companies and they don't understand healthcare. Because if you don't understand the use case, then you don't build it for the user. You build it for someone that understands JavaScript or whatever. You know what I mean? And yeah, those two problems are super intertwined. 100%.
Yep. Yeah, I think it's valid, and oftentimes people are talking past each other. So sometimes the tech company, actually the software vendor, really does understand what the clinicians want and need, but there's a middleman between them, and that's usually the hospital or healthcare administration. And these folks aren't bad. It's just that they've also got other people in between, right? They have the government, either state or federal government, between them and the outcomes that they want. They've got lawyers, they've got regulators, they've got compliance folks. And I think a lot of the problems that we face in the United States are of our own making. The same software can be taken and moved over to Europe or Canada, and it works much better because aren't these onerous requirements that either are real or imagined. A lot of what we do in healthcare, we deal with what I like to say is our imagined problems, right? It's, compliance says you can't do this thing. That's not safe. That's not allowed. You'll all go to jail. We'll all be wearing orange. And it's often, sometimes it's accurate, but most often it's not accurate, and it's just an opinion, and someone's kind of taken a little thing and made it into a big mountain, even though it didn't need to be that way. Yeah.
So what would your advice be, or maybe a framework to health systems on how to approach and not fall into that trap of overcomplicating things for their doctors?
Well, one thing that I did is I co-wrote a book about one thing, about applying principles of design to healthcare. And so I think that's one thing that folks can do, which is, hey, you've agreed on what you think is the best thing, right? So we think doctors should use this antibiotic for community-acquired pneumonia because it's the most effective and reasonably priced, and we can get a hold of it. It's not supply constrained, and lots of other reasons like that. Yet they put impediments between doing the right thing, ordering that antibiotic for patients with pneumonia, and having that outcome. And so sometimes just kind of going back to saying, okay, what are our goals here? What are we trying to achieve? It's not to fill out the paper. Sometimes it used to be, and I still hear that, like, oh, well, we need this form filled out. Well, why? Well, don't worry about the why. We have to have this form. It's on paper. We need you to make it into put it in the computer. Like, right. But what's the purpose of the form? Because often that form made sense 20, 30, 40 years ago when it was created, but it doesn't make any sense now. It's really not necessary. We could have someone else fill it out. And so just kind of following some of those principles of the way humans think and work and want to work, and getting out of the way, just allowing people to do what they normally would do and make the choices that they would normally make is the best. So sometimes a lot less is more.
Yeah. And so I actually, let's get into it. I have a little copy right here. This designed book, which should be nicely designed because it's literally called Designing for Health, the Human-Centered Approach. And so this is written by yourself and a Dr. Pagani.
Jerome Pagani was my colleague. He's I always say he's the smart one. I'm the good looking one.
No, his glasses like that. You kidding me?
He's the PhD. I'm the MD. And I think we kind of combined to really kind of talk about the realities of how humans think, right? It's not, when we talk about design in this book, at least, we're not talking about the color of your sofa. We're talking about things like, actually, there was an article just recently, putting a chair in the middle of a hospital room encourages hospitalists, physicians who spend their time in the hospital, to sit down. And what that means when they sit down, when they're in the patient's room, they sit down, they talk more with the patient, right? And they're not only talking longer, because their study actually timed how much they talk when they're standing versus when they're sitting, but now they're actually looking at the patient eye to eye, because they're down on their level, as opposed to standing up and looking down on them. This is a design. This is design, right? This is design. And although that was not included in the book because the article just came out recently, that's an excellent example of kind of like, hey, did you have a chair in the room? Yeah, we had a chair. Where was it? Well, it was folded up and it was in the closet.
Right.
And so what literally they did is they had a medical student take that chair out, put it in the middle of the room before the physician was expected to come and make rounds. And then they didn't tell the physician why. They just said, oh, well, we're doing a study. We want to see how patients react to you or whatever it was. They kind of misled them a little bit. Mm-hmm. But they put the chair in and then a bunch of people sat in the chair. And what's most amazing is, besides what the physician did, which is A, spend more time with the patient, and B, look at the patient face to face, the patient's perception of the quality of care that they received went up. That's amazing. The quality didn't go up.
It makes sense, though. Like, from a patient's perspective, if I'm talking to a doctor that's sitting in a chair, I feel like he's present. I feel like the doctor's there. I feel like I'm talking to a doctor. When the doctor's standing and check, and, next thing you know, they're out the door, and you're like, what happened?
Yeah. So why can't we do things like put chairs in hospital rooms? Again, it's a minor thing. The chair was there. It was folded up. It was in the closet. Hey, let's unfold it and put it out. And just kind of, again, you don't have to tell anyone. You don't tell people that they should sit down, but they do. And so can we apply those things also to technology as well? Can we make it easy to do the right thing? Can we default in I was talking about the right antibiotic for pneumonia? It's not always right, but it's probably right. Whatever that choice is in that local area, it's probably right 80% of the time. We'll default that in an order set, which is how physicians typically put in a lot of orders at one time. Just default it so they don't have to click it. And you're like, well, it's just one click. It's not a big deal. It's a huge deal to have just one click. So default that in, and then that's one less decision the doctor needs to make. For the 10 or 20% of the time when that's probably not the right antibiotic, oh, they were already on that. They failed that as an outpatient. So yeah, we don't want to put them on that since it didn't work already. Okay, well, that's the 10 or 20%. Now they have to make a click. But that's fine. That's completely appropriate. It's still the right thing to do, but it's not the default action. And so, applying these principles of how people think, just one click makes a big difference. I was just reading something that where one of the Google co-founders who was being grilled on why Google, his assertion was Google was not being a monopoly and didn't need to be punished or broken up in some way. And his answer, one of his answers was, well, it's, we have to be top of our game because it's very easy. It's just one click for people to change to a different search engine, just one click. And the truth is that almost none of us ever make that click. And he knows that, and behavioral scientists know that. And we're trying to get healthcare administrators to realize that as well. One little click, just putting the chair out there, little decisions that really shouldn't make a big difference make a big difference. Sharing the screen, when you're in the doctor's office and you can't see what they're typing on that screen, it's a little anxiety provoking. What are they saying about me? What are they reading about me? If I can see the screen at the same time you see the screen, that takes my anxiety level down. It lets me know what you're doing. It lets me know you're not playing tic-tac-toe or answering a message for some other patient. Right. And it's a big deal. And so those are little things but yet when you're designing a room or you're putting in a workstation, making it easy for the patient to see what the doctor's doing or the nurse is doing. It's the right thing to do. And it's actually smart from a quality perspective. It's smart from a financial perspective. It wins. Everyone wins when you follow some of these design rules.
So how long do you give us before doctors are all wearing Apple Vision Pros and they can see multiple pieces of the chart all at once while still looking at the patient? And also the technology, it has a microphone. It's picking up everything in the room. It's doing the notes automatically. How long do you give us until that happens?
Well, I would hopefully say never, because that thing is huge and it covers your face. I have tried it.
You didn't like it? I haven't tried it.
It made my eyes dry after only 30 minutes. And I think it's more of a toy right now, but I totally understand it's version 1 and it's going to get smaller and better and faster and cheaper. So I think it will be helpful. I can't imagine a physician in an exam room wearing that, because it's going to completely separate you from the patient.
So that's what I was about to say. The only way I see this working is if part of the visit, but the use case is actually, I just thought of it now, but it actually I think is a perfect use case for something like that, because you can be interacting with the patient without needing a cart, without needing a computer, without needing anything, but you could still have all the information about the patient that you need while still looking at the patient. But you need eyes, you need the person's eyes. And so I think that the only way this works is when the Apple Vision Pro, basically, and this is just total sci-fi at this point, but basically, patient walks into room, patient gets a pair, doctor has a pair, and the Apple Vision Pros, you know how it basically is augmented reality, right? So you see everything in the room, but it also knows to basically fit in my eyes and my face. Basically deletes the Apple Vision Pro from when looking through the Apple Vision Pro. Imagine that. So now I see my doctor sees me like normal.
Yeah.
And the doctor also has everything they need all around me as big as they need.
Yeah, okay. I feel like that's going to be a while till we get there, like I would settle for stuff that we can actually do in the next couple of years, which is, we could have a big monitor in the room so that when I walk in, it knows who I am. It puts up information about the patient that's relevant to me, not because I'm a doctor, but what kind of doctor am I? And what kind of information am I actually looking for when I walk into the room?
Yeah.
That would be super helpful.
On airplane seats, then they can probably do it for doctors' rooms, right? Where
you're right.
Now says like, hello, Menachem,
I think you're right. And the, like the information about, you had mentioned something we'll be recording and, taking notes and summarizing. That's today.
Yeah,
that's today. So that's happening now.
Yeah.
There's lots of companies that are exploding with LLMs now to be able, again, to transcribe the entire appointment and document it, and the physician then approves it. My prediction last year at a conference was within 5 years. I'm going to say this because I'm not putting any money in it, so maybe I'll be wrong. But within 5 years, most doctors won't be doing any type of actual documentation. We will have to learn to talk a little bit differently, right? So when I'm examining you, I'm going to have to say out loud, okay, so your ears look great, your tympanic membranes are clear and they move when I auscultate, when I blow some air in there, and all other things to kind of give the AI to let it know what I'm doing. But this is actually no different than having human scribes today who listen or are in the room or maybe in the other side of the world, but are listening to in real time and noting what the doctor is saying. So we can do that today. We'll be able to do it tomorrow. And I think we'll just be recording everything. We'll just record it. We'll audio record it. If people have privacy problems, they'll get over it. They've gotten over the fact that they wear a tracker 24 hours a day. So
I agree 1,000%.
Yeah, you'll get over it, and then your documentation, which is a major problem with physicians today. It's a big problem for them in terms of burden, because we keep being told by insurance companies and lawyers that we have to write more and more. Like, I need to know everything that happened. You know what? We're just going to record it. How about that? And we keep that recording. If you want to know what I said exactly, word for word, what did I say, you can go and listen to it. It's really cheap. Storage is really cheap.
Right.
And then our documentation can really be done by the AI, because it's much less important. We're never going to go to court with what the AI said we said. Right. We're going to go to court if we ever have to go to court with the actual recording, right? Not even a transcription. Like, we can actually record it. So again, we're not ready for that today, but I think within small number of years, 4, 5, 6, we most of us will be ready for it. And can you imagine going to a physician and saying, well, I don't want to record it, and then the physician having to do all this extra work? I can imagine physicians be like, okay, well, I'm going to see you today, but this is not how we do business in the future.
Right.
And so you're either going to have to change your attitude, or you're going to have to find a different doc. And I think that's a valid statement. Again, not today, but maybe 5 years from now.
Right. If I walked into a doctor's office and said, no, please don't use that EHR. I'd really much prefer that you do it on paper. They'll say, yeah, sorry, that's not how.
That's exactly correct. That's exactly correct. And let's be honest, if you're worried if all you are thinking about is privacy, if that's all you're thinking about, well, then we should not have electronic health records, right? The best thing for you privacy wise was paper, because it's only in one place. And the only time it's generally, broken is when doctors close their practices, which is, this happens over and over, or used to at least. They would put all of their, old charts in the garbage in the back. I've probably heard about this a dozen times over the course of 2 or 3 decades, right? And you're like, you really should have destroyed those. Right. Like, that's something that you need to chop up. You can't just throw it in the garbage. And so okay, fine. That's one area where paper is bad. But other than that, it's perfect for privacy.
Yeah. Wow.
It's just not good for taking care of patients or quality or anything like that. Yeah.
Well, Dr. Joseph, this has been a fun and forward-thinking conversation. Definitely stimulating. Where can people find out more about you? Where can they find your book?
So the book is on Amazon, Designing for Health. You can just type in those words and
Audible yet or no?
No, we don't have a recorded version yet. That might be coming in the future. We do have ebook versions though on Amazon and pretty much anywhere you can get an ebook version. Yeah. If you're interested in knowing what I do or what my company does, it's nordicglobal.com, and you can find more information about us there. And happy to talk to you and preach the gospel of design.
Love it. And LinkedIn. You can find Dr. Joseph on LinkedIn. I know that's
pretty active there. Yep, for sure.
Yeah. Well, thank you so much for joining us. This was awesome.
It's my pleasure. Thanks for having me again.